Good morning, guys. Welcome back to another vlog. I'm just waking up for night shift. I am on a stretch of 5 nights this week. It's a lot. Y'all know I don't like night shift. Even though I've been doing intermittent night shifts for 2+ years. Still very rough, and I think that maybe why it's so rough is because I'm not a consistent night shifter. Like I have, with the nature of emergency medicine, you kind of have, you know, random night shifts, then you're switched back into days, and then your circadian rhythm is messed up. So it's 12:30, and I got home around 7:30, so I didn't sleep super long. But I am currently on night 2 of 5, finished night 2 of 5, finishing out this month on nights. But yeah, just waking up. I'd have some breakfast. Stanley made some shrimp and grits, so gonna have that. So Mondays are known like pretty much as the worst day in the ER, like the busiest day in the ER. So last night was Sunday night leading into Monday, and it was good throughout the night. Then all of a sudden, like maybe 5 a.m. hits and people just start rolling in. I'm like, oh my gosh, here comes Monday. So when I know when I get to work tonight, Monday night, is gonna be busy and the waiting room is gonna be full. So what have I been up to since the last video? We took our trip to Jamaica. It was a great trip, fun, relaxing. Didn't end up vlogging because we're just enjoying our time relaxing, honestly. We stayed at a resort. It was our first time doing a resort together, and mostly kind of just stayed on the resort, did some snorkeling, a lot of pool time, a lot of good food. So that was a nice trip. And then we had the ITE, the in-training service exam, which is a yearly exam that residents take, and it kind of prepares you for your board exams and predicts how you'll do for your board exams. I know like a few weeks ago I was telling y'all that I was doing like some of the practice exams for that, but we took the official one in February. I think it went well, but we don't get our scores until like middle of April, which is right around the time that we're going on our graduation cruise. Our program gifts us every year, the residents and their significant others go on a graduation cruise. I think it's the Royal Caribbean. We sail out from Orlando and we stop in Bahamas twice, I believe, Jamaica and Haiti. So yeah, I'm definitely looking forward to that. Heading into March, which means just over 3 more months left of residency. I'm in the ER for the rest of the year. The academic year is June, so March, April, May, June. I'm in the ER for the rest of those months. I mentioned, you know, how night shift is just a struggle. I think mainly because not even staying up at night and like working through the night is not the issue. It's the next day, like how my body is feeling, getting enough sleep. I can never sleep for like a full 8 hours, which I normally sleep on a regular kind of sleep schedule for myself. I just never get adequate sleep at night. The new job I'm going to be working at, when I start my attending job in August, they have a dedicated nocturnist, full-time night shift doctor. So it's very rare that I would have to work any night shift, which is a major plus for this job. All right, y'all, it is a little bit later in the day, Monday night, and heading into night shift 3 of 5. Actually feeling pretty good. I ended up taking a nap midday, like around 5, which I don't usually do. I slept from like 5 to 7:30, and it was just what I needed. Like my eyes were so heavy from not getting enough sleep from the previous night shift. But it is Monday night. On night shifts, I park a little bit closer to the hospital entrance, and so because of that, I go in through the waiting room, and then I can always gauge how busy the night is going to be just based on how many patients are sitting in the waiting room. So, we shall see you guys in the morning. 8 hours later, and we are done. Actually, it was not a bad night for a Monday night at all. I ended up seeing about 18 patients during the shift. But yeah, 7 a.m. Getting out right on time, heading home to sleep. I am alive. Y'all, I'm done with my stretch of 5 nights, I have the energy. It is, what is it? It is about 6 o'clock. Last night was my last night. It was a Wednesday night, and on Wednesdays it's single coverage as far as residents. It used to, usually every night we have double coverage for most of the night, but on Wednesdays we have single coverage, and it's because on Thursdays we have our conference days, and so the other resident gets off to allow them to attend conference. And so you can imagine single coverage, you're seeing all the patients, it can get pretty busy, pretty backed up. But last night was a pretty good night. Throughout this night shift stretch of 5 nights, I've been seeing a lot of patients, almost averaging about like 1.8 patients an hour. And to give you a perspective, like maybe a busy kind of hospital will see 2 patients per hour, meaning if you have a 10-hour shift, you would see 20 patients total, average out 2 patients an hour. So the past few nights I've been averaging maybe like around 1.8 patients per hour. So kind of busy there. But yeah, it was a solid stretch of nights. I have a couple of days off before I start back on day shift this weekend. Man, night shift is just truly about efficiency. Like, you just need to move the patients through. Like, typically you come in on night shift, you look at the tracker, and the waiting room is just full of patients that need to be seen and dispoed. The way it works, a patient will walk into the ER. They have a medical screening process that's usually done by an APP. So an advanced practice provider, either a nurse practitioner or a PA, will see them, get the history, do a quick exam, and then put like all the orders in. And then once everything is back, we then, either the resident or attending, we then go see that patient and dispo them, either admit them or discharge them home. And so by the time night shift comes, patients have been just like stacking up throughout the day in the waiting room, and the waiting room is just full and packed, you know, by the time the night shift comes. And so that's kind of what night shift is like, just clearing out the waiting room. And it can be a lot. It can really be a lot, but that's, you just have to move through, be efficient, see the patients, get them dispoed efficiently on night shift. That's kind of the name of the game. But if it was my choice, I'm day shift any day of the week. Give me my 7 a.m. to 4 p.m. That's probably my favorite shift right there, that morning day shift. The other shifts are like a 3 p.m. to midnight. I'm not really a fan of that one. I just prefer to start early and have my day done early and have the rest of the day to myself. I'm trying to think if I had any interesting cases the past few days. Kind of the typical bread and butter things. A couple of fractures, dislocations that we had to reduce. Did some procedural sedation. A few stroke alerts, a STEMI. Some things that are common through the ER are like OB-GYN complaints, like vaginal bleeding or miscarriage. And oftentimes that goes through our care path area. So it's one of the NPs or the PA seeing those patients. But because like night shift is just sometimes solo coverage or less coverage, we end up seeing those patients. So I did have a couple of those, one ectopic pregnancy and then one miscarriage. So, you know, unfortunately for the patient, it's unfortunate for the patient, but for us, you know, we get that experience of treating and managing those types of patients. A while back on one of my vlogs, I mentioned that I wanted to kind of do like a teaching segment, like one emergency medicine topic every vlog. I haven't followed through on that, but I will do one on this vlog. So I'll do that tomorrow. I'll think of like a common ER complaint, just give a brief kind of like management of that. But I have today off, so Stanley and I are gonna go out tonight. Gonna go to Oak, it's a little restaurant bar downtown, and have some drinks and some food. All right.
Oh, really?
Just got a package delivered. Pretty sure these are the Girl Scout cookies that my friend sent me.
Guess what?
Thin Mints. Favorite kind of Girl Scout cookie right here. Thanks, girl. Haven't had Girl Scout cookies in years.
Sugar, sugar.
Y'all hear him in the background talking about sugar. I told him that I want to cut out added sugar for my diet and like sweets and stuff. So now every time I have something, he's reminding me and holding me accountable. Everything in moderation though. Oh.
You got donuts.
Who brought those donuts into this house?
For myself.
I told you to start bringing that stuff into this house. Oh my gosh.
I will hide it.
All right, y'all, we are heading out for a little date night downtown. Mine or yours?
Yeah.
Okay. Ready? Good morning guys, happy Friday. I was able to sleep in this morning, which is pretty nice. Just having a little breakfast, some yogurt. I'm gonna make some avocado toast. Last night we went to Oak downtown, which is a little subpar. Last time I was there was for brunch and it was great. It was a great time. They had a little nice R&B playlist going on, good food. Food that we had yesterday wasn't really that good, and the drinks weren't that great either. But anywho, we move. Today I have the day off, and I think I'm gonna go to the gym, and then we're probably gonna go to dinner at Embers tonight. Oh, and the topic that I'm gonna talk about today is GI bleeds. A relatively common complaint in the emergency department, and we should all know how to manage GI bleeds if we're going to be working in the ER. This avocado has been here for a while, so let's see how it's going to look. Looks fine. Okay, so I actually gave a talk on GI bleeds in January when I was rotating in the ICU. All right, so GI bleeds, we divided up into upper GI bleeds and lower GI bleeds. The management can vary a bit depending on where you think the source of the bleeding is from. So pretty much starting with upper GI bleeds. What even causes upper GI bleeds? It could be from peptic ulcer disease, perforated peptic ulcer, gastritis, esophagitis, maybe a Mallory-Weiss tear, Boerhaave's, cirrhosis like esophageal variceal bleeds, which are very scary, and these patients can be very unstable. It could be maybe some kind of fistula like aortoenteric fistula, so a connection between the aorta, the large artery going through the entire body, and then some part of the GI system that can cause some bleeding. So those are the upper GI, some of the upper GI causes. Lower GI causes could be like diverticulosis, some kind of diverticular bleed. It could be hemorrhoids, Cancer is also a big one. If somebody's coming in with lower GI bleed, cancer in an older patient is something you could think about. Polyps is another one. And then oftentimes upper GI bleeds present through like the lower GI tract. So even though they're having bleeding from their bottom, it could be from an upper source. And so how are these patients going to present? The patient is coming in and you're suspecting a GI bleed. What would their presentation be like? They can come in literally saying, I've been vomiting blood. And then obviously you're going to be thinking of an upper GI bleed. They can be saying, every time I go to the bathroom and I'm having a bowel movement, there's bright red blood in the toilet. Or they can say something like, I'm having black stools, black tarry stools, and that should point you to actually an upper GI bleed, because that blood is getting digested in the upper system and then it ends up being, comes out as black bowel movements. Another thing when it's not an obvious bleed can be that they just come in just so weak, just generalized weakness, generalized fatigue, maybe lightheadedness, maybe syncope, they passed out and finally decided to come to the ER. You do a workup and you see that they're anemic. Once a patient is anemic, after that, you need to figure out where potentially bleeding is coming from, and you have to do a rectal exam. That's very common in the ER. We have to do a rectal exam, get a stool card, and if you see that it's positive, if it turns blue, they're likely having a GI bleed that is causing their anemia. You would admit them and have GI do a scope on them. So those are some of like the physical exams, how they'll present. And then if they're having an active bleed, you know, what are some of the vital signs that you may see? They may be hypotensive, they may be tachycardic, they may be hypoxic because they're not getting good oxygenation. So those are some of the physical exam signs. So you see the patient, assess the patient. Resuscitation is so big for GI bleeds. Like I said earlier, these patients can become very unstable very quick and they can crash very quickly. So resuscitation is key, making sure they have 2 large bore IVs in, starting IV fluids on them. You're gonna send off labs. Type and scream is important because oftentimes these patients will be transfused. Get a CBC so you can check what their hemoglobin is and the hematocrit is. Get coags, so that's your PTT, your INR, to see if maybe they have some kind of coagulopathy that needs to be corrected. You're gonna get a chemistry, see what their BUN and creatinine is. That can sometimes clue you into also if it's like an upper versus lower GI bleed. Elevated BUN, that can indicate an upper GI bleed source. Get a troponin, get an EKG. Plus or minus on a CT of the abdomen. It really depends on the clinical picture. For every GI bleed that comes through, I do not get a CT abdomen. If they're having like an upper GI bleed, maybe, you know, I don't necessarily go to it. Indications for me to get a CT abdomen will be if they're having profuse lower GI bleeding, like large amounts, because the point of the CT abdomen is you're gonna do the GI bleed protocol. So you're gonna look at the arterial system to see if you can see an active bleed. And oftentimes you won't see it unless they're having a large amount of bleeding. That's when I'll order it. And if you end up seeing the active bleed on the CT, you would consult IR so they can do an embolization, so they can go in and clot off that artery that's bleeding. All right, you identify that you have a GI bleeder on your hands. You sent off labs. You got some IVs in, 2 IVs in at least. You started some fluids on this patient. An important question that you should ask, are you on blood thinners? If you have a patient that is actively bleeding and is on blood thinners, you potentially should reverse their anticoagulation. This is going to be on a case-by-case basis. You need to see what they're anticoagulated for. Some people truly need to be anticoagulated, which is why they're on blood thinners. But if they're having a life-threatening GI bleed and they're on anticoagulations, most likely you're going to be reversing that. So if a patient is on Coumadin or warfarin, you're going to be checking the INR, seeing where it's at. It's interesting. I actually had a case a few weeks ago, a GI bleeder coming in actively lower GI bleed. They were on Coumadin. They were pretty unstable, hypotensive, tachycardic. In that case, we're not even going to wait for the INR. We're going to go ahead and give 10 milligrams of vitamin K. So vitamin K is the reversal agent for warfarin, because if you look at like the pathophys or the pharmacology of it, vitamin K is like a dependent factor for for Coumadin to work, and so giving vitamin K will reverse the effects of Coumadin. So typically, you know, you would give the vitamin K for warfarin reversal. If they're on another med like anticoagulation, let's say like heparin, you would give protamine sulfate. There's other ones like Eliquis, or some other ones you may give PCC or Kcentra. So if they're on a blood thinner, see what they are on and then see what the reversal agent is. You may have pharmacy in your emergency department, so you can kind of collaborate with them and kind of determine based on when their last dose was, how much of the reversal agent should be given, but reverse anything that needs to be reversed. After that, blood. You know, IV fluids is only going to do so much when these patients are actively bleeding, when they're unstable, hypotensive, tachycardia. You need to give them blood because they're losing blood. And you need to determine if they need to be on a massive transfusion protocol. And that's when you give a ratio of packed red blood cells to platelets to FFP to plasma, essentially. And so that patient I was talking about the other day, we did do a massive transfusion protocol on this patient. So in addition to the IV fluids, you should be resuscitating with blood products because they are losing blood. And then after that, just depending on what kind of patient you're dealing with and what kind of GI bleed you're dealing with, you would give them certain medications. So if a patient is presenting with the upper GI bleed, they're vomiting blood, you know that they have a history of alcohol use disorder and they have a history of cirrhosis, you're going to be concerned about an esophageal variceal bleed, which can become very unstable, which is kind of a scary presentation. But these patients, you should be giving them IV Protonics because that decreases the chance for rebleeding in them. So Protonics is a proton pump inhibitor, antacid, so you should be giving them a bolus of that and potentially starting them on a drip. You should be giving them antibiotics because you're concerned about bacteremia, and specifically something called SBP, spontaneous bacterial peritonitis. There's a high chance that these patients with liver cirrhosis and who have GI bleeds can become bacteremic, so you need to cover them with antibiotics. Specifically, we'll do like a 3rd generation cephalosporin, so ceftriaxone in that case. You would give them a medicine called octreotide, and what it does, it goes to the splanchnic system and it vasoconstricts, so it tries to decrease the bleeding. So those are the three things that are big for cirrhotics with potentially esophageal bleeds: Protonics, octreotide, antibiotics. And then like the lower GI bleeds, there's usually nothing specific as far as medications. It's just resuscitation fluids, giving them the blood products that they need, making sure they're hemodynamically stable, and ultimately you will get these patients admitted and likely admitted to the ICU. And usually within 12 to 24 hours, you want the GI specialist to do a scope on them and to see, you know, where that bleeding is coming from after they've been stabilized a bit better. Also, a thing with the upper GI bleeds, you need to assess their ability to protect their airway, and potentially they may need intubation. So if you're actively vomiting, there's a chance that you will aspirate, you know, have the fluid go into your lungs. So these patients, you have a low threshold to intubate early. So yeah, that's kind of it, really, like a short summary of GI bleeds. You know, the name of the game is truly resuscitation early. Make sure they have good IV access, start the fluids, give them the blood products that's needed, see if they are on a blood thinner and reverse that blood thinner as needed. And then depending on the type of GI bleed this may be, there's specific medications that you need to give them. So yeah, I like treating GI bleeds. It can become an algorithm, just depending on what it is. And then, you know, figuring, it won't be your job to figure out the source of bleed. It's mainly stabilize and resuscitate the patient and then get them off to the appropriate unit, and then having GI see them and scope them. All right, so please provide some feedback on the little talks that I do. I know last time y'all said, I think I did a brain bleed one, and y'all gave me good feedback on that. But let me know if y'all like to see more, if this was too dense, if y'all would like it a bit shorter, if y'all want any specific topics, let me know. Man, now that my exam is done, I took my IT exam in February, the end of February. It's just such a freeing feeling that I don't like have to study for anything. I don't have any exam to prepare for. That was the last exam that I ever had to take in residency. And now that I'm going to be finishing residency in June and then becoming an attending, you have to do your board certification exam. I'll be taking that later in the year, like in November. Then after that, you just have to recertify every few years. It depends on your specialty. Maybe every 5 to 10 years you'll take, you know, the recertification exam. But yeah, it's just like I could just relax. I'm not studying for any exam. There's nothing that I have coming up. Obviously, you know, lifelong learner in medicine, you know, you'll study as you go, look up things as you go, but it's just like I'm not studying for an exam. I'm studying to, you know, learn for my patients and become better. All right, making a little lunch, Brussels sprouts and some salmon. Actually ended up staying in tonight. Make some pizza instead of going out for dinner, and I'll go ahead and wrap up the vlog here. I have an early day tomorrow. I'm working 7 a.m. to 4 p.m. working this weekend. So yeah, I hope you guys enjoyed this vlog. If you did, make sure you give it a thumbs up. Make sure to subscribe, and I'll see you in the next one. All right.